Good morning, good afternoon, good evening, depending on where you are watching this Getting to Zero episode that brings to you insights and perspectives from leaders and luminaries striving to reduce preventable maternal and child deaths to zero. If you are interested in knowing about our future conversations, be sure to like this video and also subscribe to our YouTube channel below. Today we welcome Dr. Abhay Bang. He's a highly inspirational physician and researcher whose groundbreaking methods of living and working among tribal communities of India have drawn global acclaim. He and his wife Rani trained in public health in India and later at Johns Hopkins University in the USA, and have selflessly used their expertise to reduce neonatal and infant mortality rates in India. They were instrumental in conceptualizing the ASHA and home-based newborn care model that was scaled up under India's flagship National Rural Health Mission that I had the privilege to lead. Some of their thinking and practices have been adopted globally. So many people from across the globe visit their amazing foundation called Surge and spend time learning firsthand from their community-rooted work. I hope I will be able to do that sometime soon. Welcome, Dr. Bang, and thank you so much for speaking to us today.
Namaste, Anuradha ji. It's pleasure seeing you on the screen and listening to your voice. Go ahead, please.
So, Dr. Bang, my first question. Do you agree that globally progress on reducing maternal and child deaths has slowed down? And what, in your view, are the most important steps that need to be taken to accelerate progress? What pitfalls have you witnessed at a policy and implementation level that you think must be rectified?
I live in a place called Gadchiroli, which is a remote tribal area. And so my view is really view from the grassroots. And I lack the bird's eye view or the global view. I hope that I'll be able to share some of the grassroots realities with you. But to address your question, maternal mortality, especially in India, but world over, has significantly reduced in the past 25 years. And the credit must go to the global initiative by researchers, by activists, by advocacy people, lobbyists, and then international organizations, and then finally to the governments who implemented it. So maternal mortality, for example, in India, when I started working in community health, it was around 500. Now it is around 100. So if one compresses this on time scale, it's a revolution. A large-scale shift from home delivery to institutional delivery has made significant change in maternal mortality. And so maternal mortality has stagnated, partly because it has reduced to significant level, and there is a law of diminishing return. It is easy to reduce at the beginning, but as you reach the lower level of mortality, then every further step is more and more difficult. It depends on which part of the world you are. But for example, the place where I live, Gadchiroli, currently heavy monsoon rains are going on and the rivers are full, nalas are flooded, all roads are cut off. Nearly 500 villages in Gadchiroli district today are cut off. Now, any woman who gets into labor pain in a remote tribal village will find it absolutely impossible to reach institutions if she needs. So still, institutional care is inaccessible to some part of the world. There are nearly 120 million indigenous or tribal people, as we call them in India. There are 12 crore tribal people. There are large tracts of rural areas where services are not immediately accessible. And maternal malnutrition, maternal anemia, and several reproductive tract infections, they all contribute to maternal morbidity. To complicate the matter further, tobacco is quite prevalent even amongst women. And so all this together contribute to maternal morbidity and mortality. But I would say maternal morbidity is a more significant issue now, and fortunately maternal mortality has significantly reduced. Child mortality, no question, there has been steep reduction in the past 25 years. Nearly two-thirds of child mortality has reduced, and we have now globally around 5 lakh, half million child deaths occurring every year. Though one would consider this even also a tragic thing. But then we have made significant progress, and there are several factors. I don't have to go into why we succeeded, but if there is a feeling that we have not made progress and we need to make further progress, it is genuine feeling. But the reason I think is world is very variable stage. There are areas in Africa, there are areas in India which are tribal areas, there are areas in South Asia where healthcare is not accessible. Maternal education and women's status is the most important factor for reducing child mortality. Community health workers are a very powerful solution for reaching out to those millions of mothers and children with simple solution like oral dehydration for diarrhea, immunization for all immunizable diseases, ARI management or pneumonia management provided by community health workers, and home-based newborn care which we developed here. These are the 4 programs or interventions which can rapidly reduce child mortality. But one major factor which we have not yet overcome, especially in India, is child malnutrition. And child malnutrition provides the soil in which child mortality occurs. We have not been so successful in reducing child malnutrition so far. And my guess is, having worked in this area for 40 years, child malnutrition will respond to economic growth, to women's education, and finally it will take 1 to 2 generations to completely get rid of child malnutrition.
That was so insightful, really reminding us of the tremendous progress that has been achieved on reducing both maternal and child mortality, but also the fact that we are now getting into very local issues and heterogeneity, because contexts vary and therefore, just the importance of promoting community-based healthcare with local models. But my next question to you is that when you first came to Gadchiroli, which, as you rightly said, is a very remote tribal part of India, you encountered quite a lot of resistance from local interests, including the alcohol industry and several others. In many ways, the health professionals we work with today around the world encounter similar local resistance, which is made worse by misinformation. What strategies or approaches would you advise for them to win the trust of those they are seeking to serve?
In 1986, when we came, and immediately few months after we came here, we did something which was the most important lesson for me in the past 40 years. And it probably partly answers your question. That's why I'm getting into it. A girl, 8-year-old girl, was referred to me as a suspected case of heart disease. And I suspected she probably had sickle cell disease. There was no test and no case had till then been reported from this district. So we found out that it was sickle. Now, I had freshly come back from the US, and so all ideas of research and first case reporting and publication, etc., were going on in my mind. And in that enthusiasm, we conducted district sample survey for sickle. Found out that nearly 15% population had sickle gene and 1% had sickle homozygous. Government honored me. This was published in research publication, but actually nothing happened. So we went back to tribal leaders in villages that they should try to bring pressure on government that something should be done for sickle. Now look, when Rani and I went back and talked to them, they looked at us with mask face. And they flatly told us, "Doctor, did we ever tell you that sickle is our problem? You came and you asked for a drop of blood. We thought, why discourage a young doctor couple? So we gave you a drop of blood. We have nothing more to do with this disease that you call sickle. You discovered it. It is your problem. You solve it. We realize that we public health experts or doctors like us, in our young enthusiasm, we try to impose our perceived problems and priorities on the people. And that was, I think, the most important lesson that we learned. And then we changed our strategy. Instead of our perceived priorities or global programs and global priorities to be imposed on local people, we organized People's Health Assembly, and we asked people to tell us on which health problems they wanted us to work and provide care and do research. And you will be surprised, 30 years ago, through People's Health Assemblies, by way of voting, we identified 6 priorities. 3 of them are well known: malaria, diarrheal disease, and child mortality. But 3 were relatively unknown in public health. Low backache. We had never heard this as a public health priority. Alcohol and alcoholism. And women said, we have weakness problem. And by weakness, they really meant gynecological problem, white vaginal discharge. And so this provided us agenda. I told you this story because the local resistance, some of it is vested interest. So you naturally have to face it. They have, vested interest has its own economic reasons. So understandable. One shouldn't paint them as a villain, but look at them with little sympathy that if they lose business because of public health, expansion of public health knowledge and programs, some people are going to get hurt and they will struggle, they will resist. That is understandable. But some of the resistance we encountered for public health programs at the grassroots or from amongst the people is because we push wrong priorities and we really don't make people's priorities as our priorities. And if we make it, a lot of local resistance vanishes and you may get much better support. For example, for alcohol, women were insistent. We talked with them about health problems of women. My wife Rani is a gynecologist. And women said, doctor, keep your stethoscope aside. Don't tell us about your tablets and medicine. Our husbands drink alcohol and they daily come and beat us. Can you do something for this? And initially as a doctor, we wanted to avoid this issue. Who wanted to get into alcohol business? But finally they forced us to take up that issue. And that has provided, it led into a massive public movement against alcohol. All commercial sale of alcohol has been banned by government in this district for the past 30 years. And that has provided us very good base in about 1500 villages where we work. So begin with people's priority, and for that one has to listen to the people. So listen to the people, begin with people's priority, and then you develop better allies and friends rather than foes and resistance.
So this is so inspiring because you have sort of explained how it is important to understand the needs of the community and how you actually understood that need through a certain process of learning. Dr. Bang, you have also written about the difference between action and thinking action. And I know a lot of people, who also want to do similar research and, organizations that are also looking to adopt a similar approach of putting people at the heart of their research initiatives. I think they would really benefit from the distinction that you have made between action and thinking action. Would you want to just elaborate on that a little bit?
Look, whatever I said, it again came from my own experience. It was not really some theory. I grew up in Mahatma Gandhi's ashram. And so naturally, the impression and the examples around me were all of service to the people. And so it's not surprising that I decided to take up medicine and worked in rural area. My natural impulse initially was providing service. But soon, Rani and I realized that there are limitations of service. Service programs definitely ameliorate the immediate health problems of the people, but A, they don't reach to the root cause of the problem. So the root causes, they keep on generating newer and newer problem. And actually what doctors get is an employment guarantee scheme. That newer diseases, newer patients are always generated and we keep on firefighting. Secondly, we also realize that for local people, service is their need. But you can't solve larger problems only by way of service approach. And so, like the famous saying goes, that think globally, act locally. I would like to really turn it around and also say, think locally. And it produces global action. And this is what we have been doing. We have turned our work with the people in nearly 100,000 population, which we have been following for last 38 years like a population laboratory. On one side, we provide them service, healthcare service, various community healthcare programs, but we try to turn everything into public health research. And most of the time we fail, but sometimes we succeed. And when we succeed, some new knowledge emerges which very often has influenced even global thinking and policies. This has repeatedly happened. This is nothing great about me or Rani or search. This is the beauty of the approach, that if you listen to the people, start with the local priorities rather than going by international priorities because they are fashionable. Funds come easily for international priorities, but avoid that temptation. Listen to the people, begin with local epidemiologic priorities, try to develop new solutions. Usually this is very creative as well as very difficult because there is no precedence. So you have to really work in the unknown. But that's why it's very creative also. But it gives you an enormous advantage that you can very easily become a pioneer. It is so easy to become a pioneer. Go to the area where nobody has gone, work on the problems on which nobody has worked, and you become a global pioneer. So easy. But so converting local priorities and local action into research action produces enormous knowledge power which can contribute to shaping global thrust. And that's what I either call think locally, and it itself acts globally.
So beautiful, Dr. Bang. You have actually turned the I would say the global dictum on its head by saying, we have to think locally. And that is what will drive global impact. Rather than think globally, impose those priorities on local communities, which have very different needs and aspirations and priorities. And that is why, in my view, we are now seeing that stagnation because, the low-hanging fruit in public health has already been reaped. And now as we get into, marginalized, vulnerable communities, sometimes the global community describes that as getting to the last mile. I think this is becoming even more and more important. So really a lot of wisdom in what you just said. But just let me probe this a little bit more with you and say that when you are advocating, and rightly so, for an approach, that brings this whole emphasis on local thinking and local action, what do you think will it take to move away from the current model, the current global model, to put ownership, money, and power in the hands of those who can trigger and enhance local impact?
It will, it will need nothing less than a revolution, and so it will be a very long-term dream, that sort of thing to happen. But let me, in one lifetime we can walk only few steps, and we can see few changes only. But the few changes, let me suggest, When I returned from the US with my Hopkins MPH, and we were thinking where to settle, what work to do in India. In Delhi, I met an old man who looked little like Mahatma Gandhi. And he asked me a question that you have studied public health. I said, yes. So he said, what is India's Indian definition of health? And in my 10 years of learning medicine and then public health, nobody had ever asked me this question. I told him WHO definition. He brushed me aside. It's a Western definition. Tell me Indian definition. I didn't know. I had to admit. So he said, and Anuradha ji, you will understand because it has Sanskrit origin. What he said, what do we call health or healthy person in India? I said, swastha. He said that very word itself is Indian definition of health. जो स्व में स्थित है वो स्वस्थ है. One who is autonomous, one who is not dependent on others for taking care of himself is healthy. One who has to depend on others is unhealthy, asvastha. So in India's very word, the definition of health is hidden, and in that definition of health, freedom, liberation from dependence is embedded. So Indian definition of health is independence, autonomy. I think that health increasingly tends to become doctor dependent, hospital dependent, drug dependent, and all these things are costly. And so naturally you need government support. And this is all, increasingly it makes more and more dependence. And dependence itself is unhealth. And hence, first change we need is to change definition of health rather than providing health care, universal health coverage. We should be able to really provide universal capacity to take care of health. Empowerment for self-health or community health or even national health. The circle expands, go on expanding, but the capacity and empowerment is more important than actual delivery of healthcare. So we need to really transfer capacity, more and more capacity. Second thing is that non-communicable diseases have become more important, and to a large extent for non-communicable diseases, either economic policies are important or our own lifestyle choices are important. So these need a major change. These are all really partly depend on self, my choices. And in case of, for changing this relationship that you mentioned really to begin with, so this change is necessary because today doctors, scientists, drug industries, hospital industry, we experts, we are at the top and people are at the bottom. An empowerment approach would make people at the top and we would be helping them from the sideline. Secondly, India has partly done it, is that decentralization of decision making to some extent, because from the national capital or state capital, you cannot really come to know about local priorities, local difficulties. And so a decentralized model of healthcare decision making, priority choices, it's important. And I'm sorry if I'm going to slightly criticize global policies, but when I read about Millennium Development Goals, Sustainable Development Goals, they are all very well intended. They provide the policy push for governments to move in a particular direction. They are very well intended. But the question is, should global priorities also be Gadchiroli's priorities? Or Gadchiroli's priority will be different? And how will local priority be accommodated in the global priorities or national priorities? So it's a question of power relationship. It's a question of who makes decision, who decides resources allocation and resource distribution. And finally, it is our research culture or knowledge culture, which gives the expert the power, the international organizations the power, governments the power to us. I also belong to the same community. But then, finally, what we need is not research on the people. Usually, most of the time, our researches are research on the people. I have a 4-stage framework to move away because knowledge is so important in health. Knowledge is the power, it is the basis of power. So, from research on the people, we need to move to research for the people, then research with the people, and finally, one day, research by the people. When people will acquire more and more capacity to generate new knowledge and find new solutions, this power inequality that you mentioned at the beginning would really, that would be reversed and people will be at the top.
Absolutely, very well said, Dr. Bang, that this whole power structure and power dynamics need to be completely turned upside down if we really want progress to happen and people to be healthy. And as you rightly said, define locally what health looks like and really devolve that power on people and communities, because it is their agency which is actually going to sort of take us in the direction of outcomes that everybody, including the global community, is hoping to accomplish. And I think I really like the thought that you brought forward, that it actually would need a revolution, because currently none of us are thinking like that at the global level, at the national level, even at the subnational level. So if we look at the provincial governments, they're also not thinking like that. So priority setting is either done by the provincial government or the national government or the global ecosystem. But are we going to people of Gadchiroli or other such areas to say, okay, you decide your own priorities and your agenda, and power, ownership, and resources are going to be fully devolved on them, because there is a certain amount of confidence that everybody places in their wisdom. So I think it's also the confidence that global and national and subnational level is such a fascinating conversation, Dr. Bang. We could have carried on, but we are bringing this conversation. We have to bring this conversation to a close. So my last question to you is, your career advice to a public health student at Johns Hopkins University, where you also got your MPH, was go to places where nobody wants to go. Is that still your advice for those starting their global health careers?
I have no better advice than that. But then that advice actually originates from where I grew up. Look, my father was a very brilliant professor of economics. He had record number of gold medals in university, but he joined freedom movement, and then when India was about to get independence, the new Indian government decided that they wanted to send this young, bright economist, part of freedom movement, to the US for studying further. So he got his admission for PhD in the US university, visa, etc. Everything was made. And 1 week before his scheduled departure, he went to seek Mahatma Gandhi's advice. Gandhi knew him personally. So Gandhiji was sitting in his hut, bamboo hut, on the ground, was writing something. My father went, he was 28-year-old at that time, bowed to him and said, Bapu, I am released from jail and now I am going to the US for studying economics further. I want your blessings. Now I am describing what my father told me. Gandhiji looked at him for a few seconds, then uttered only one sentence. He said in Hindi, but let me say in English, that if you want to study economics, go to the villages of India instead of going to the US. My father came out. He tore away his admission papers and scholarship papers right outside Bapukuti. And within 1 month, he went to live in a village adjacent to that place. And I was born when my parents were living in that village. And so it's no great thing that we decided to go to villages. There is such a beautiful history for that. But at the end of my 40 years work in Gadchiroli, If a new upcoming public health person or expert or student asks me a question, I would say the best strategy for you would be go to the places where nobody wants to go. Go to the places where there are no facilities. Because places with facilities have no problems to be solved. There you become a problem. Instead, go where there are problems and there are no facilities because nobody wants to go there. And there is no dearth of research problems and research questions waiting to be solved. So it is so easy to become a pioneer, as I said earlier. So I would still really, yes, I would say that go where the problems are, go and work with the people, and if you are lucky, you might become a global pioneer. But even if you don't become global pioneer, still your life will be very meaningful and happy. I can't imagine more rewarding life.
And on that highly inspirational note, Dr. Bang, I really want to thank you for your time and for sharing this wisdom with our audience, which I'm sure have many young professionals who would benefit enormously from the advice that you have just shared with them. Thanks a lot for speaking to us. Thank you.
Thank you, Anuradha.
Thank you.